Thank you, Mr. Chairman, for your kind introduction. Good morning, everyone. First of all, I'd like to thank the organizing committee of VSRMN NM Society meeting for inviting me to this symposium. It's a truly great pleasure and honor for me to be here. Today, I'd like to talk about the value of EOB-MRI in clinical diagnosis of HCC and also importance of early detection. So as you all know, HCC is the most common primary liver cancer, and it is third leading cause of cancer-related deaths worldwide. It could be a cause of death more than 600,000 people per year. In Vietnam, as the prevalence of chronic hepatitis B is very high, HCC prevalence is also significantly higher than other parts of the world. HCC is truly a big health problem in Asia, including ASEAN countries and also China, Korea, Japan. Curative treatment can be applicable only for early stage, but HCC is frequently diagnosed at its late stage. Survival can be different depending on stage at detection. For example, if you detect early stage HCC, the patients may have a longer survival than 5 years, whereas if cancer is detected at its advanced stage, the usual 5-year survival rate is less than 20%, and mean survival is less than 2 years. So here you can see BCLC guideline for management of HCC, and as you can see here, for the very early or early stage HCC, we can provide the curative treatment options such as ablation, surgical resection, or liver transplantation. However, once the tumor is detected at intermediate stage, maybe TAC is the treatment of choice, and the survival time is less than 5 years. And if you detect the tumor at its very advanced stage, the systemic therapy, including recent immunotherapy, is the treatment of choice, but survival is usually less than 2 years. So we need, as a clinician, we need a duty to detect HCC at its early stage. Then how we can detect HCC early? There are several imaging options to use for detecting HCC. And as you can see here, there are APASL, AASLD, EASL, and Korean guidelines. As you can see, those guidelines include several imaging modalities, including contrast-enhanced CT, dynamic MRI, and EOB-enhanced liver MRI. And in Asian and Korean guideline, it includes the SonoView and Sonazoid enhanced ultrasound. Although American guideline did not include CUS, EASL also includes contrast enhanced ultrasound, and SonoView is the contrast agent. So as you can see here, all the major guidelines include the EOB-MRI. Here you can see the typical imaging features of HCC. Once you can see the nodule showing FE, arterial phase hyperenhancement, and also washout on CT or dynamic MRI, you can make a definitive diagnosis of HCC without biopsy. Then what would be the sensitivity or specificity you can expect from these imaging features? Actually, sensitivity is not that high, below 70%, usually 50% to 70%. Conversely, the specificity is very high, higher than 95%. But you need to consider which is more important in Asian countries. So considering high prevalence of HCC and also wide use of local regional treatment options for HCC, early detection of HCC is more important than having the high specificity. So if you want to improve the sensitivity of imaging test for HCC, what would be the best option? According to meta-analysis paper, EOB-MRI is one of the options. So if you can see the sensitivity and specificity, of contrast-enhanced CT is 74%, and if you use dynamic MR with ECCM, 78%. If you use EOB, 86% of sensitivity could be expected. So how we can improve the sensitivity using EOB? Actually, EOB is a hepatocyte-specific MR contrast agent. Once the contrast is injected into the patient vein, after first circulation, it starts to uptaken by hepatocyte via OATP transporter. So the contrast medium can enter into hepatocyte according to the physical characteristics of MR contrast media. If the contrast is located within intracellular space, the enhancement power is 2 to 3 times stronger than that in extracellular space. So if you compare portal venous phase enhancement with the hepatobiliary phase enhancement of the liver after injecting EOB, hepatobiliary phase imaging provides much stronger enhancement of the liver. So that gives a very good advantage for detecting small focal liver lesions. So most malignant lesions, including HCC, do not have OATP transporters. On the contrary, hepatocyte have OATP transporters on the cellular membrane. So liver enhances very homogeneously and also with a very strong degree. On the contrary, focal liver lesions show hypoenhancement. Therefore, we can have a very good contrast between focal liver lesions and the liver background. So we can have very high staging accuracy. Furthermore, in cirrhotic liver, one of the common false positive lesions would be AP shunts. As liver fibrosis increases the post-sinusoidal pressure, the portal blood flow cannot enter into sinusoid. Therefore, arterial hyperperfusion occurs, and then AP shunt commonly shown. And then those lesions show arterial hyperenhancement. Therefore, they can mimic HCC. But with the EOB, the hepatocyte in the AP shunt region may possess good functioning OATP transporters. Therefore, they show ISO enhancement on hepatobiliary phase imaging. So we can easily differentiate AP shunt from HCC. Furthermore, as we can evaluate OATP transporter function with the EOB-MRI, we can indirectly evaluate liver function, and also this OATP transporter decreases during hepatocarcinogenesis, so we can detect the borderline lesions much earlier than ECCM-enhanced MRI or contrast-enhanced CT. Here you can see the graphs showing the liver parenchymal enhancement. With the EOB, you can see the gradual and higher degree enhancement. Therefore, we can have a better contrast between focal liver lesions and background liver. And with that characteristics, we can detect the very tiny malignant lesions, as you can see here. You can see these very small 5 millimeter HCC lesion. Of course, you can see those lesions on arterial phase, but many of these kind of nodules may not show washout. On the contrary, on hepatobiliary phase imaging, you can see hypoenhancement. If you add high-quality diffusion-weighted imaging, by combining diffusion restriction information and hepatobiliary hypoenhancement, you can easily make an early diagnosis of a small HCC. Here is another case of HCC. Here you can see typical imaging features of HCC, AFI, portal washout, and hepatobiliary hypoenhancement. No problem. But in the upper level of that slice, you can see two small tiny enhancing lesions, one in segment 4, the other in segment 8. And then among these two lesions show different enhancement patterns on the hepatobiliary phase. The anterior one shows iso enhancement, whereas posterior one shows hypo enhancement. And this posterior one was confirmed as an HCC, 5 millimeter HCC, and in this area, there was no tumor on intraoperative ultrasound. So that means we can easily differentiate a patient versus a small HCC, which is very beneficiary for making accurate staging of HCC. And during hepatocarcinogenesis, the HCC usually develop through multi-step from DN, high-grade DN, early HCC, and finally progressed stage HCC. During the hepatocarcinogenesis, initially arterial blood flow may decrease, and then at the final stage, it increases. So if you see arterially enhancing HCC, that's already progressed the stage HCC. Then before that stage, how can we detect such kind of lesions? EOB can reveal such kind of regions more effectively than CT or ECCM-MRI, because during hepatocarcinogenesis, OATP function and number is gradually decreased. So many of early HCC show hypo enhancement on hepatobiliary phase imaging. According to our study, EOB-MRI was significantly better than CT for detecting early HCC, which is pathologically vaguely nodular HCC. Here is a typical example of early HCC. Although this nodule shows T1 high, T2 low signal intensity, which are the overlapped imaging features of this dysplastic nodule, on hepatobiliary phase imaging, you can see clear hypo enhancement. Once this nodule shows either diffusion restriction or T2 high signal intensity, it is more likely early HCC. Then what's the clinical meaning of detecting such kind of lesions? If they are early HCC, once you treat them with local ablation treatment, there is a significantly lower rate of local recurrence. Pathologically, there is no evidence of microvascular invasion among early HCC. Even small HCC, like a 2 centimeter small HCC, depending on its morphology, the prevalence of microvascular invasion could be up to 20%. And also, the presence of this kind of nodules may provide a very good prognostic information for the patient. So let's compare two patients. Both patients have similar size HCC, but the other liver background doesn't have this kind of borderline nodules, and this patient have such kind of nodule. What's the clinical meaning? Actually, these nodules may develop progressed HCC quite frequently. So up to 30% of these nodules will convert into hypervascular HCC within 3 years. So background liver is bad. So background liver has a higher risk of developing HCC. So you need to consider this kind of things when you select the treatment option. Here is a case of HCC, and then using left lateral sectionectomy, the patient, the tumor was removed. But at that time, there was a 5 millimeter size hepatobiliary hypoenhancing nodule. 1 year later, the nodule shows interval growth and arterial hyperenhancement. As you can see here, small hypoenhancing nodule may convert into HCC up to 30% of these nodules may convert into HCC within 3 years. So this kind of information would be very important. And then what would be the impact of HCC patient management? Early detection via EOB-MRI provides better chance to receive curative therapy such as surgery or ablation. And also, as EOB-MR can depict the morphological features of HCC more accurately than other CT or ECCM MRI. It could be important to choose adequate treatment option. Accurate staging also allowed tailored therapeutic strategies. So as you can see on this diagram, depending on stage, the ideal therapeutic option is different. So once you determine to use local ablation treatment, tumor size and tumor morphology are very important to predict the local recurrence rate. If the tumor morphology is more irregular like this, confluent multinodular type, it possesses a higher risk of microvascular invasion. And also, tumor size is bigger than 2 centimeters or 3 centimeters, the prevalence of microvascular invasion is increasing. So with the local ablation treatment, this kind of microvascular invasion is not well treatable. So surgical resection would be better. Here is a case. This tumor shows irregular multinodular confluent type morphology on hepatobiliary phase imaging, and we suggested surgical resection rather than ablation. On surgical resection, microvascular invasion was found. So that kind of information could be beneficial for your clinicians. And also, according to this paper from Asan Medical Center in Seoul, they reviewed the patients who received surgical resection for single HCC. And then, depending on availability of a preoperative EOB-MR, they compared the two groups. One group has a pre-op CT imaging only. The other group has CT plus EOB-MRI. And then CT plus EOB-MR group had a longer survival and also lower recurrence rate. So it is quite meaningful. And also with the EOB-MR, BCLC stage upgrade happened in 13%. That means treatment option should have changed according to that information. That's the reason why the patient group have better survival. And also, if you combine the tumor marker and the enhancing features of HCC on EOB-MR, you can predict the prognosis. For example, 90% of HCCs show hypo-enhancement on hepatobiliary phase imaging. 10% of HCC may show iso or hyper-enhancement on hepatobiliary phase imaging. The issue is whether these tumors may show different prognosis. The answer is yes. When HCC shows hepatobiliary hyper-enhancement, it is more likely beta-catenin mutated type HCC, and then the prognosis is much better. And also, when the tumor is showing peritumoral arterial hyper-enhancement or hepatobiliary hypo-enhancement or irregular tumor margin, it suggests a high probability of microvascular invasion, which suggests poor prognosis. So using the enhancing pattern of HCC on EOB-MR, you can predict prognosis. Here is a two case. So 90% of HCCs can show hepatobiliary hypo-enhancement, and 10% show hyper-enhancement. So upper one is bad guy, lower one is good guy, although they are similar in size. And among HCC, there are some aggressive, biologically aggressive subtypes, which are proliferative type, or this feature type. So this proliferative HCC usually show much higher rate of recurrence, and on pathology K19 positive, or on pathology fibrosis is common, or macrotrabecular massive type tumors. And these tumors usually show rim arterial phase hyperenhancement. So which is LRM feature. So once HCC show this kind of atypical arterial rim enhancement pattern, the prognosis is much worse. Here is an example of a microvascular invasion case, and you can see the peritumoral arterial hyperenhancement and an irregular tumor margin and hepatobiliary hypoenhancement. So prognosis is worse than the other tumors. Finally, I'd like to briefly compare the guidelines. So with the EOB, there are several diagnostic criteria according to the international guidelines. In Western side of the society, they put an emphasis on high specificity because liver transplantation is widely used. In that situation, portal phase washout is used for defining the washout phenomenon. In Asia, including Japan and Korea, we are using hepatobiliary hypoenhancement as an alternative washout sign. But there is two conditions. One is we need to exclude the hemangioma. We need to exclude the cholangiocarcinoma. So once you can exclude the lesions showing T2 bright high signal intensity or rim Fe or targetoid appearance, we can use hepatobiliary hypoenhancement. So the major reason why Western society try to use portal washout rather than hepatobiliary hypoenhancement is hemangioma, as you can see here. Although this is a hemangioma, on 3-minute delayed scan and hepatobiliary phase, the lesion shows hypoenhancement. So it may mimic HCC. However, due to bright high signal intensity on T2, you can make a correct diagnosis. And according to our study, once you reliably exclude hemangioma by using T2 bright high signal intensity or rim enhancing lesions or targetoid appeared lesions, we can use hepatobiliary hypoenhancement for increasing sensitivity while maintaining reasonably high specificity. So 90% sensitivity, 90% specificity could be achievable. So you need to know which is rim Fe. So left side is a typical HCC, non-rim Fe HCC lesion. The right side lesion is rim Fe and targetoid lesion. So right side lesion is cholangiocarcinoma and left side lesion is HCC. So according to the criteria you use, you can make a different diagnosis. Here is a case of HCC showing arterial hyperenhancement and portal isoenhancement, hepatobiliary hypoenhancement. So if you use Asian guideline, you can make a correct diagnosis of HCC, whereas if you use a Western guideline, you cannot make a diagnosis. So I explained the major reason why Western society use the strict criteria. So in conclusion, EOB-MRI demonstrates the value for detecting and characterizing focal liver lesions in cirrhotic liver, and it can help to improve the management of HCC, and also it can provide useful information for predicting prognosis. Finally, ideal criteria for HCC diagnosis on EOB-MR are not yet clear, and I hope the Vietnamese Radiological Society can put heads together to create ideal criteria for your own clinical environment. Thank you very much for your kind attention.